The following are salient features. From these, we identified hemorrhage, hypovolemia, coagulopathy, and neonatal distress as disease processes. In pregnant patients presenting with bleeding, timing may provide clues. On admission, there were no clinical signs of an active bleed. With a shock index of 0.7, we can say for sure that there was no massive bleeding. Moreover, our patient satisfies the POG's definition of postpartum hemorrhage. Hence, we have good reason to believe that initial chief complaint was no more than bloody show. Therefore, etiologies of PPH are more likely. Particularly, we look into tissue, trauma, thrombin, and tone. With hypovolemia, coagulopathy, neonatal distress, these are our considerations. Uterine atomy is the most common cause of obstetric hemorrhage. However, there are no risk factors such as uterine overstretch, as by Hadlock, fetal size was in the 50th to 70th percentile. Moreover, abdominal palpation showed a contracted uterus. Hence, uterine atony in itself cannot explain bleeding at its onset. Bleeding despite a contracted uterus is suggestive of lacerations. In this patient, a second-degree laceration was identified and repaired. Further, the amount of blood lost is not compatible. In the absence of or with minimal trauma, mucosal bleeding is suggestive of a coagulopathy. In a patient with unremarkable bleeding history, an acquired coagulopathy is more likely, but no clear inciting factor can be identified. And although an AVM in pregnancy may cause hemorrhage, it is unlikely in a patient with no pelvic pain and no history of abnormal uterine bleeding. Now, we are left with these considerations. The acuteness of disease progression makes AFES likely. However, the absence of sudden pulmonary maternal compromise preceding fetal hypoxia make it unlikely. An abruption would explain mucosal bleeding prior to vaginal bleeding due to a DIC in the picture of a concealed hemorrhage. It would also explain neonatal outcome. Contrasting AFES and abruptio, in terms of salient features earlier identified, we can see that the picture presented by our patient is more congruent with abruptio. At this point, allow me to digress and point out gaps in information, which we could have used in order to come up with a more clear-cut diagnosis, such as the gross appearance of the placenta, CTG tracings, or the paternity of children. Taking the case as it is, however, this is our primary impression. How does abruptio account for our patient's clinical presentation? Our patient was admitted with signs of labor. At this point, there already was a concealed hemorrhage secondary to a partial placental abruptio. Hence, no apparent bleeding was seen in our patient. The first stage of labor progressed unremarkably. Laboratories revealed microscopic hematuria, and gum bleeding was later seen. These are notable in the supposedly prothrombotic state of pregnancy. In this patient, it can be explained by a starting consumptive coagulopathy via two mechanisms. First, decidual bleeding leading to hemorrhage, increasing intervenous space pressure, and second, decidual hypoxia leading to the release of VEGF and inducing thromboplastin production. These two serve to aggressively introduce thromboplastin into maternal circulation, thus hyperactivating extrinsic coagulation cascade. From there, the baby was delivered. It was the delivery of the placenta that led to the release of the concealed hemorrhage, resulting to massive postpartum bleeding. This bleeding first was aggravated by the DIC, and second, further aggravated the ongoing DIC. As such, bleeding persisted with signs of hypovolemia and prolonged coagulation parameters. This problem in coagulation explains why our patient continued to deteriorate despite transfusion with packed RBC. In addition, previously contracted uterus was later found to be with soft lower uterine segment as a result of hypoxia from blood loss and increased hypofibrinogenemia and FDP in DIC. All this led to a systole and shock in our patient. At this point, let us not forget that we have two patients. We also have a baby born with poor Apgar score and neonatal respiratory distress resolved after only several days. This is suggestive of a fetal hypoxia-inducing acute insult. In an abruptio, it can be explained by decreased placental perfusion. Taken together, this presents a complete and comprehensive picture of placental abruptio as it is presented by both patients. We go further and question, would DIC really explain this rapid progression of bleeding? And second, why are our coagulation parameters so severely deranged compared to platelet count? We looked into the possibility of other disease processes as surrounding circumstances, risk factors such as proteinuria, spontaneous abortion, obesity, led us to question whether this was also a case of preeclampsia. Studies showed that proteinuria alone may be the first sign of an impending preeclampsia, which would explain marginal hemoconcentration, nucleated RBCs in maternal blood, and masked hypertension seen as a BP of 110/80 given estimated blood loss. A review of literature revealed that a diagnosis of a typical preeclampsia can be made in these types of patients. Hence, we believe that our patient has a typical preeclampsia, which is an undisputed risk factor for abruptio. Further, decreased antithrombin levels in preeclampsia would also explain disinhibition of thrombin, leading to a hyperactivated coagulation pathway and the increased consumption of factors, seen in our patient as a uniquely very deranged coagulation parameters with normal platelet count. This cascade of events led to our patient's demise with hypovolemic shock secondary to intractable hemorrhage, secondary to DIC, due to an underlying intrapartum placental abruptio with a typical preeclampsia. Thank you.